My name is Amber Huff. I'm a research fellow at the Institute of Development Studies, and this lecture covers the topic of emerging infectious diseases and the political ecology of disease emergence. Emerging infectious diseases, or EIDs, are an important priority in global health, as they account for at least 12% of all human pathogens. They're also the focus of a great deal of research and a persistent source of public alarm. This lecture covers a series of topics related to understanding emerging infectious diseases from different perspectives, including demographic, epidemiological, and political ecological perspectives. We address questions of what are dominant ways of thinking about health patterns and change? What are emerging infectious diseases? Where do they come from? And what are different approaches that researchers and policymakers can use to address the threat that they pose to public health? Epidemiological transition theory was first proposed by Abdel Omran in 1971. The theory describes a general shift from acute infectious and deficiency-related diseases, characteristic of underdevelopment, to chronic, non-communicable diseases characteristic of advanced levels of development. The epidemiologic transition, as it was originally set forth, was designed to provide a general picture of the major determinants of death that prevailed during several distinct periods in Western, meaning Western European and North American, epidemiologic history. It is a way to think about how changing patterns of mortality, or causes of death, and how changing patterns of mortality affect different age and sex groups of the population, and how these changes in patterns of mortality impact survival and life expectancy within a population. We can sum up the basic mechanism of the model of the epidemiological transition as development, defined specifically in the theory in terms of technological and scientific modernization or progress. This mechanism affects demographic change, or the empirical characteristics of populations. According to the theory of the epidemiological transition, as nations modernize, they tend to improve their social, economic, and health-related conditions, which causes specific types of demographic shifts, resulting in different epidemiological phases. The three phases of the epidemiological transition proposed by Omran's original model included Stage 1, the age of famine and pestilence, Stage 2, the age of receding pandemics, and Stage 3, the age of degenerative and man-made diseases. Each phase is associated with particular types of health systems, social characteristics, and environmental characteristics. The first phase proposed by Omran was what he called the age of pestilence and famine. In such a setting, as we see boxed in on this chart, birth rates, shown in pink, are high, and the mortality rate, shown in blue, is high and fluctuating. This results in slow population growth and low and variable life expectancies of between 20 and 40 years. The population is predominantly young, and there are more men than women due to the high risk of maternal death during childbirth. A model of this phase might be Western Europe prior to 1830. Characteristics of this phase of the transition would include, for example, frequent epidemics and famines, chronic malnutrition, high rates of endemic infections and parasitic diseases, high rates of maternal and child health problems, and unsafe environments in general, characterized by, for example, dirty water, lots of fecal contamination, pests, and poor housing conditions. During this age, health systems most often are thought of in terms of indigenous health systems, with traditional healers. Isolation and quarantine of the sick is the only reliable means to combat the spread of infectious disease, and there is yet no immunization. The population would be primarily rural, but with a few crowded, epidemic-ridden cities. The second phase, the age of receding pandemics, would have been seen in, for example, North America from about the mid-19th to mid-20th centuries. According to this pattern indicated on this chart, mortality progressively declines, with the rate of decline accelerating as epidemic peaks decrease in frequency. Average life expectancy increases steadily from about 30 to 50 years. Because of this, population growth is sustained and begins to increase exponentially. Characteristics of this phase of the transition would include epidemics and famines, somewhat reduced in frequency, people living long enough for heart disease and cancer to become more common. Infection and parasitism are reduced somewhat from the previous phase. Occupational health problems rise, particularly traumatic injuries. Sanitation begins to improve. Urban health problems become more severe, and accidents become more common. During this age, people would see improved nutrition and rising living standards, the beginning of the sanitary revolution, including systematic refuse removal, sewer installation, cleaner wells, etc. Quarantine becomes more strictly enforced to curb epidemics. Antiseptic practice makes operations possible. Immunization is invented, and organized health services emerge. The population is still young, but the proportion of older people begins to increase. Because of medical advancements, male-to-female ratios are nearly even. The population is also on the move in an exodus from farm to factory, from rural to urban. In the third proposed phase, the age of degenerative and man-made diseases, mortality continues to decline and eventually approaches stability at a relatively low level. As a result, life expectancy rises and exceeds 50 years for the first time in human history, with fertility becoming the crucial factor in population growth. Characteristics of this phase of the transitions would include morbidity from age-related chronic diseases, mental illness, addiction, and pollution rising in importance, overshadowing mortality as an issue of concern. Infectious diseases are isolated to certain groups of people within a population. Occupational health dangers are primarily electrical and chemical. Geriatric care becomes a dominant mode of health care, and the cost of medical care rises dramatically. Comprehensive, organized health services are common with both curative and preventative capabilities in this society. Rigorous sanitary measures are in place throughout society, and screening for certain diseases becomes routine, as widespread measures are in place to prevent the spread of infectious disease. There is a progressive aging of the population as fertility declines and more people, especially females, survive to old age. Most people live in urban areas, and along with the rapid growth of cities, there is also alarming growth in the formation of slums, the amount of environmental pollution, and social and political problems. As the risk of dying from infectious diseases is reduced for a population, those saved from dying from such diseases survive into middle and older ages, where they face the elevated risk of dying from degenerative or man-made diseases. It's true that historical changes and transitions have impacted infectious disease exposure and susceptibility in human populations. These changes include big demographic, economic, and social transitions. For example, the transitions from hunter-gatherer to agriculture societies that happened in human history. They include travel and colonization, the development of hygienic practices, vaccines, and antimicrobials, increasing human population, increasing animal populations living close to humans, livestock keeping, domestic and peri-domestic animals, globalization of movement, including colonialism, travel, and trade. The concept of health transitions is influential in global health and in the international financial institutions that fund development. The model of health transitions suggests that nation-states, as they develop, go through predictable epidemiological transformations. However, understanding population health is not so straightforward. Complex factors influence susceptibility to disease and rates of different health problems in different populations. Development is neither a straightforward concept nor a linear, directed process throughout the world, and a great many factors affect the ways that people are exposed to health threats and access healthcare and sanitary technology. The ways in which these factors impact health depends on how the factors interact with one another and complex local and national histories and political conditions. Linear thinking that simplifies and universalizes these processes can mask these complex realities. The epidemiological transition has, in the past, been thought of as a process beginning when infectious diseases were predominant and ending when non-communicable diseases dominated the causes of death. However, new patterns of health and mortality are challenging these ideas. We'll discuss two of these in a moment. The model of the epidemiologic transition is based on a particular reading of recent Western epidemiological history. Epidemiological change is more complex and dynamic than the model would have you see. The health and disease patterns of a society evolve in diverse ways as a result of socioeconomic, technological, cultural, environmental, and biological changes. As with ideas about modernization in general, assumptions of linear progress and universal applicability of the model can mask complex realities on the ground. The model is apolitical and privileges changing medical technology, disease, and especially in the later stages, individual behavior as causative of mortality. While epidemiologists, including Omran himself, have come to acknowledge diversity in the experience of health transitions in different places at different times, dominant thinking about changing health patterns and development often remains tied to linear and apolitical thinking regarding health patterns. We now turn to continuing critiques of the transitions model that highlight new and important questions. What of structural, political, and economic factors that result in differing levels of development and constrain public health systems and access to health care and technology? How do class-based and global inequalities shape patterns of health? How can we account for the persistence of infectious and parasitic diseases around the world despite the existence of effective technologies to treat and cure them? And how do we approach context-specific dynamics influencing health? Since the introduction of Omran's epidemiological model, researchers have documented emerging health patterns that are not accounted for in the standard health transitions model. Stuart J. Olshansky, a biodemographer, and a number of other authors have made contributions to the debate on transitions by proposing new phases based on emerging evidence. For example, the age of delayed degenerative disease describes a pattern in which life expectancies peak and age-specific mortality rates decline due to advances in medical technology that prolong human life exponentially. However, this pattern is primarily limited globally to wealthy settings. Furthermore, a proposed fifth phase is that of emerging disease, which seeks to capture rising threats from infectious diseases that have surfaced since the 1970s. This photograph shows two veterinarians performing a bovine necroscopy in the United Kingdom, looking for evidence of bovine spongiform encephalopathy, or mad cow disease. The standard definition of an emerging infectious disease, or EID, is an infectious disease whose incidence has increased in the past 50 years and could increase in the near future. The WHO definition of emerging infectious disease is one that has appeared in a population for the first time, or that may have existed previously, but is rapidly increasing in incidence or geographic range. Emerging infections account for at least 12% of all human pathogens. There are both practical benefits and limitations to the language of disease emergence. Benefits include communicating a sense of urgency for action, focusing widespread attention on real health risks, generating high-level discussion and policy action, generating new sources and streams of funding for health programs, and political support for crucial research activities. Related to the language of disease emergence is the way that it tends to be used and the ways in which it captures the public imagination. Emerging and re-emerging infectious disease arguably capture media and public attention like no other health problem. The dominant popular and panic-ridden notion of emerging infections sees these pathogens as representing the threat of coming plagues that will emerge without warning, spread rapidly, and overwhelm global health systems. When we think about infectious disease emergence and reemergence, often images of novel pathogens coming out of remote wilderness areas comes to mind. While this image is not fully inaccurate, in that, yes, sometimes novel pathogens are documented in rural areas, it's not correct either, and it really is sometimes arbitrary. It all comes down to really the positionality of who's examining the problem and their definition of emerging. Just as there are practical benefits to framing health risk around disease emergence, there are practical limitations and drawbacks. For example, sensational media coverage can spread misleading or inaccurate information and can distract from attention to actual causes of illness and suffering in the world. The common language of emergence, according to some researchers, packages highly complex phenomena in a much too simple language instead of conceptual tools. This can limit thinking around causation and risk. And the language of disease emergence in and of itself can be misleading. Many so-called emerging diseases are not in fact new diseases or new to humans. What is new is the pattern, range of risk, or scientific documentation of them. The tendency to focus too much on the emergent aspect of a disease can distract from asking deeper questions about causation and about underlying ecological and social dynamics that put people at risk.